Well, good morning. I'm the nurse practitioner for the Department of Urology at Medical University. I will tell you, everybody spoken so far has been a man, so they didn't leave it at home. The only way they left it at home is if it was out in a bucket somewhere, having been taken out from a prostatectomy. We have to remember that as men, we have to be very vigilant in what we do with our bodies. We worry about everything else. We worry about skin cancer, we worry about heart disease, but we also have to worry about our prostates. If you look at the statistics just from 2011, 240,000, almost 241,000, and 33,000 of those people died. South Carolina, 550 deaths. This is just from prostate cancer. If we start looking at how often that is, so 24.7 out of every 100,000 men will have the incidence of it. In South Carolina, 28.9 out of 100,000. But when we start looking at deaths, look at it. All of a sudden, we're up to 60, almost 61 men, African American men, out of 100,000 will have this. So we start looking at, well, let's compare African Americans and Caucasians. So it's 1.63 times more likely that you will have prostate cancer if you're African American. How about death? It's 2.44 out of 100,000 times more likely. So when you look, that is a huge number. And when you start looking at the number, people say this is not a big deal. This is a big deal. So the best thing I've heard so far is everybody says they want to be educated. Well, let's look about how many people die from this. If we just look at over a lifetime, how many develop or die from prostatic invasive cancer? In African Americans, 1 in 5 will die from it. 1 in 6 of Caucasians. So that's a fairly significant disease in men. And if you go to church tomorrow, you tell every man to stand up and 20% of them sit down, they just died from this disease. That'll impact what you start thinking about this. Go to a football game right down the street here and have 20% of the guys sit down, and those are the people that die from this disease. So this is not a minor disease. Why do people not go? Hello, I'm Dr. Grossfinger. I'll be your urologist. Everybody's worried about this thing of screening just because it's a digital rectal exam. Well, let's look and see what the professionals say. Now, first thing I'm going to tell you is if you look at the American Cancer Society, if you look at the American Urological Society, they're going to give you C recommendations, which means that there's something there that says that there's some tendency or some recommendation they can make. The U.S. Preventive Services Task Force, which is probably one of the more controversial groups, theirs are D recommendations. It's basically their opinion. There's nothing that they have to stand on to make their recommendations. But let's look at the American Cancer Society. They'll tell you asymptomatic men who have at least a 10-year life expectancy should have an opportunity to make an informed decision. Doesn't mean you have to be screened, but it means that you make an informed decision. That in itself is screening. That means that you sat down with your healthcare professional. Maybe it's your doctor, maybe it's your nurse practitioner, your PA, maybe it's somebody that's had prostate cancer. You have to make a decision. You have to be informed. You have to know, what really lies out there. If I get screened, what are the potentials? If it's positive, do I have to do something? If it's negative, am I clear for the rest of my life? What are the risks of being screened? There's good things and there's bad things about being screened. Some of it is there's the potential. If your PSA is high, they want to go do a biopsy. They do a biopsy, what are the risks there? And then what are the benefits? If you see, several men today have talked about, I was 50, I was 55, I was 60 when I was diagnosed. They made a decision based on a discussion. But the average risk for most men, we should start at 50. Now this is according to the American Cancer Society. But if you're African American, if you're men that are at higher risk, and this is something that's already been mentioned, if you have a father and a brother that was diagnosed before age 65, you should start at age 45. If you're men with higher risk, several relatives diagnosed at an early age 40. Again, this is what Dr. Bell just mentioned. And unfortunately, we have a whole group of people that don't share information. Everybody thinks prostate cancer is a secret. So you've got uncles and brothers and dads that won't tell people that they have prostate cancer. Yet what they don't realize is their children and their children's children are going to be at risk for this. So it's kind of selfish in that manner. So what did the American Cancer Society say? Well, first, they want everybody to increase trust and credibility. This is a great underserved segment. If you look at the numbers just in South Carolina of deaths, why do they die of prostate cancer? Most of it's because they don't get screening. If you look at doing evidence-based stuff, unfortunately, only one that has anything that's evidence-based is the American Urologic Society. Granted, they have a reason to be, it's kind of self-serving in their rate, but at the same time, they at least are looking at the thing from a scientific viewpoint. There are some disparities. There's some horrible disparities in this country dealing with African Americans. They don't get screened. Some of it's fear, some of it's just it's lack of people being able to do that. If we look at and we enhance ways to get community outreach, I speak to several of the AME churches in Charleston, and we talk about doing things to enhance health, but also to actually be involved and be active in what you're doing every day to be able to make some differences in these community outreach. And we look at things like exercise and food and diabetes and smoking, trying to make an impact on their overall health, to make an impact on their prostate health. And then we need to be involved. Everybody needs to be involved with the Cancer Society, whether it's just simply supporting what they're saying or supporting something they're doing. It doesn't take anything to go out there and walk 3.1 miles and raise $1,000 for the American Cancer Society to maybe help somebody be diagnosed that otherwise wouldn't be diagnosed. So what does the American Urologic Association say? Well, very rarely do they find...
2 minutes. Two minutes, sir.
Very rarely do they find anybody under 40 is recommended. Routine screening in men between 40 and 54 is not. Shared decision making is recommended for men aged 55 to 69. Again, importance of education, importance of sitting down with somebody and actually talking to them about the problems. Reducing the harms, and we're coming up with some new ideas and maybe ways that we can decrease some of the risk and some of the harm that can actually come from biopsies. And then after you're over 70, there's no reason to be routinely screened. If you're over 75, you need to just tell your primary care not to do that anymore. That's because then your life expectancy is less. U.S. Preventive Task Force, asymptomatic prostate cancer, they talk about substantial percentage have asymptomatic cancer with no or slow progression. If you have symptoms, it is way too late. Okay, so that is not even, I don't know why that's even said. Overdiagnosis was 17 to 50% based on their things. So their interest is three categories: cancer death regardless of treatment, good outcomes in the absence of screening, and early diagnosis and treatment. So screening reduces deaths by 1 per 1,000 screenings. If you're that one, it's an important thing. But we have false positives with PSA test. We have pain and fever and bleeding, infection, and urologic problems once you've been screened with a biopsy. 1% of people with biopsies will have hospitalization. There's some problems with treatments, and we'll talk about that later today. But again, these are D recommendations. There's a moderate certainty that PSA-based screening outweighs the harms. Shared decision making is important. Black men and family history of prostate cancer is important. If you've been a veteran and you've had Agent Orange exposure, it is critical that you get followed up on this. And there's obviously more needs for research to be done. So what's involved is simply a PSA, which is a blood test, a digital rectal exam, which takes all of 10 seconds, 15 seconds to do, and a firm medical history. We have to make sure that we understand about prostate cancer, what are the benefits of screening and treatment, and then are we going to do this as an individual? What we don't want to do is we don't want the government to tell us what to do. Okay? We are people. We are humans. We are medical people that are trained to do this. We don't need the government intervening in that. We need people that make good, solid screenings based on their individual decisions. Decisions have consequences. Okay? And okay.
I apologize about that.
That's okay.
Okay. Well, thank you very much for your presentation. First, we'll take questions from the various sides.
What are the risks of being screened?
What are the risks? Well, a blood test is fairly simple, but you can have a bruise. It can hurt a little bit, and it can take about a minute off your life. And I don't say that to be flippant, but a blood test is nothing. We get blood tests all the time for everything else. Why don't we get a PSA drawn? That's really not a good reason not to have it done. As you've heard, most of these people have not based their decisions on one PSA. They've seen PSAs over the course of time. So I think that's one risk. Second is they're very clear when they say it can cause harm. It can make you very nervous if your PSA is high, but it can make you you could have prostate cancer and not be treatable if you sit there and wait on it. As far as biopsies, as far as digital rectal exams, yes, they're uncomfortable, but they're not dangerous. Biopsies have issues. You can have bleeding, you can have pain. Some people will, they will get infections and require hospitalization. That's 1% though. So other than that, outside of screening, the big issue is, okay, if you get screened, what are you going to do about it? But if you don't know you have cancer, then you're not going to get treated anyway.
Go ahead.
Yeah, you talked about how there's a genetic difference between us and our white brothers, but and I know I saw in the news not long ago where some movie star found that she had the gene that said she could have breast cancer, and she cut off both of her breasts. I know we're not going to do that as men if we found out we had a gene. We ain't cutting anything off. But what I'm trying to find out is there any research been done to see if we have a gene to show that we could be susceptible to having prostate cancer?
Yes, there is. There's actually a fair amount of research being done. The question is what we do with this, and we're still looking. There's some programs at MUSC right now that they're looking at some proteins and ways to treat this, or ways to at least have a better predictive value.
Even because people have a family history doesn't mean that they're going to develop it. It just means that they're going to need to be screened. So I think that's going a bit far.
Buddy Melted, Spartanburg. I presently have a PSA of 5.08. Doctor has recommended a biopsy, but I've heard that you could also do an MRI to detect prostate cancer. Is that so? Do I have that option?
Did you hear the question?
Yes, I heard it. Okay. I was going to leave MRI out of this because it is still not a proven thing. We're actually looking at to initiate a study with MRIs. There's no way an MRI can prove that you have prostate cancer. It can show cells that look abnormal, but once you have the diagnosis, it's actually quite good at being able to follow prostate cancer or to tell you exactly where it is. The problem with it is, unless you have a tissue diagnosis, you really can't treat that appropriately. You can see prostatitis, you can see cancer, but there's no one at this point that's going to be willing to treat you based on that. Now, there are people that are willing to follow you with active surveillance, which we'll talk about later today. But yeah, I wish we could, and we are looking at a study right now with that.
I think the other take-home point is that the PSA is like the red light coming on your dashboard. It doesn't necessarily mean that you have prostate cancer. It just means that something may be going on and some additional tests may be needed. One of the other things that I want to point out to you is that in some patients that I have seen have had PSAs of 25, and we found out that it is a prostate infection as opposed to prostate cancer. So the PSA doesn't always signal that something bad is going on. It can be a prostatitis, which can be treated with medications. Okay, one thing. I've seen PSAs of 1 where somebody had prostate cancer. I've seen some people with levels as high as 25,000 that were dead within 6 months. So I mean, I've seen all ranges. So. And I'll take the privilege as the moderator to mention that there are a number of studies that have shown where African American men do not get offered the PSA. But now that the health literacy of black men has increased significantly, if you have a doctor who has not offered you the PSA and you have asked about it to him, then I recommend that you find another doctor. That would be my recommendation. Easy. Okay.
We have questions. Florence has 2 questions.
Yes. Okay, go Florence. Go Florence.
Yes, I came in kind of late, but what is the normal PSA for a man.
We'll go to the presenter for that question, for that answer.
Yeah, it's still read at 0 to 4 as being quote normal. Again, when you have a PSA test, we look at more. It's just a test. That's all it is. It's not a diagnosis. So you're looking at trends in PSAs. So if you have a PSA of 1 and it goes to 4 the next year and 7 the next year, that's an issue. If it's 2 and it goes to 1.9 or 2.1, that's still a stable thing. So I don't think anybody's going to get very excited about that. But if you see trends up, you're more concerned about there being cancer cells that are reproducing. The 0 to 4 is still considered quote normal.
This is the Gibbs Cancer Center in Spartanburg. You briefly alluded to Agent Orange. How important is Agent Orange as a carcinogen for prostate cancer?
If I had an exposure to Agent Orange, I'd be sitting on my doctor's doorstep the next day if my PSA went up, because it is critical. The VA recognizes that. There's a disability at the VA for that. You need to be screaming loudly if your PSA is up and you've had Agent Orange exposure.
I might add that it's not only for prostate cancer, but it's for other cancers as
Bladder
well.
and lung
So
and
if you are a veteran and you were exposed to Agent Orange, you need to be screened for not only prostate cancer, but also it's been associated with diabetes. I want the presenter to explain one thing though before he leaves. We mentioned that there is a lot of controversy from the United States Preventive Health Service Task Force. Can you explain to the audience what the controversy is?
My biggest concern about them is they don't make solid recommendations based on research. They make it on a bunch of guys sitting in a room making decisions, and it's in my opinion, and this is my opinion, okay? My opinion is that they are a task force that's there to save money. If you don't treat people, if you don't do PSAs, you will save money. You will have people die from their disease.
I agree with that. One of the final things that I would like to say is it is very, very important for you to have a good relationship with your primary care physician. If you don't have the wherewithal to have a computer to know about the issues that we are discussing, then you want to have a serious discussion with your doctor and have him to give you the pros and the cons of having the test. In many of the African American men that I have seen in my practice, number one, a lot of African American men don't even know their fathers or don't have a relationship with their fathers. So therefore, they don't know what their history is. And then in a significant segment of the African American male population, even if they knew their fathers did not discuss with them what the issues were. All right, it is kind of like a secret in the African American community, and we are trying to get rid of this. We are trying to get people to be more to talk about their family history more with other members of the family, so that you can get screened early. So that would be my recommendation. I'd like to next question from where now?
Yeah.
Columbia.
Go Columbia.
Okay, I've heard a lot of information about prostate that I really didn't know anything about. I'm 58 years old, and I just recently had a physical and suggested to my doctor, which he went along with it, to be tested for prostate. But my question is, is having your prostate removed the only solution of curing the problem?
No, absolutely not. And I mean, we'll talk about that later. But I think that's one of the problems with screening. Everybody goes, okay, so I get screened. If I have prostate cancer, now what do I do? There's two things. And if you look at my last slide, it says be proactive, be informed. Dr. Bell just said, have a good relationship with the person that you're talking to. If you can't trust them, go find somebody you can trust. If you can't trust them, call me, because I'm going to tell you the truth. I don't do surgery. I don't do radiation. I treat patients. So, I mean, if you email me, I'll tell you, listen, if this is what you got, you need to make some decisions.
Yeah, here's one question. Why is it necessary to have that finger wave? What is the physician looking for with that procedure?
You're trying to feel, there's several things. You want to feel how big the prostate is, because sometimes it's not prostate cancer. It's just how big are you having urinary symptoms? And so it gives us an idea of how big the prostate is. Secondly, if you feel a nodule, then you know where you're heading. Okay, you know that you're looking at biopsy. So that's where you. Now, how many people are really good at feeling prostates? I feel over 1,000 a year, so I'm pretty good at it. But it's interesting. I felt just out of interest, I felt 3 guys' prostates that had nodules in the last month. And when we asked them to come in for their biopsy, none of them showed up. All of them were unfunded. None of them had insurance, so I had 3 guys that probably had prostate cancer with elevated PSAs, with a positive digital rectal exam, and they never showed up, and they won't answer their phones when I call them. So part of this is fear. So don't be scared of a digital rectal exam. I don't have big fingers. I mean, it takes me 10 seconds to feel your prostate.
I think here's something that you may want to consider. I don't know how many of you can see me on camera, but if you take your thumb and put it next to your hand like this, and then feel how it feels on the top there, that's how the prostate should feel. It should feel kind of spongy. But when it has nodules in it, and when it's hard, and when you put your finger, when the doctor puts his finger in, it feels a little enlarged, then that gives a signal that something may be going on. It doesn't make the diagnosis. It's just another modality that we use to make, to help make the diagnosis. Any other questions in any other sites?
And Florence, yes, I have a question for Dr. Turner and Bell. So
yes,
just listen at what both of you have said. Do you recommend one over the other, or both?
Well,
are you talking about the PSA and a digital rectal exam?
And the finger stick. Do you recommend one over the other?
All the above. Both.
All the above. Both.
Yes, and I totally agree with that. I think it's important to do both of them annually. I encourage the black men that I see. Now, I must tell you that they don't always agree with it, but we definitely make that recommendation. It's 10 seconds of discomfort that could possibly save your life.